Hello, everyone, and welcome to the TMA Ask the Expert podcast series. Today's session is entitled Understanding and Managing Neuropathic Pain. My name is Roberta Peche, and I am the Research and Project Manager at the Transverse Mellitus Association. We are a nonprofit focused on support, education, and research of rare neuroimmune diseases. You can learn more about us on our website at mellitus.org. We're very pleased to welcome Samuel Huge from the University of Texas Southwestern Medical Center in Dallas to host our podcast today. Sam is a research coordinator at UT Southwestern and is a certified clinical research professional through the Society of Clinical Research Associates. Sam manages the UT Southwestern Neurosciences Biorepository and focuses his attention on rare neurologic conditions. He coordinates multiple studies on demyelinating diseases in adult and pediatric populations. Thank you, Sam, on behalf of the TMA. Before we begin, a few housekeeping pieces. This podcast is being recorded and will be made available on the TMA website at mellitus.org. And during the call, if you have any additional questions, please send them to us via our Facebook page at facebook.com/mellitus.
Great. Thanks, Roberta. I'm honored to introduce our guest today. Dr. Scott Newsom with the Johns Hopkins Multiple Sclerosis and Transverse Mellitus Center specializes in the care of patients with neuroimmunological and neuroinflammatory disorders of the central nervous system. He has special interest in evaluating and treating patients with multiple sclerosis, transverse myelitis, neuromyelitis optica, and stiff person syndrome. Dr. Alan DeSena is currently the TMA James T. Lubin Fellow at UT Southwestern in Dallas, Texas, pursuing a career in clinical care and research in rare neuroimmune diseases. He is the first pediatric neurology fellow to study this rare spectrum of neuroimmunological disorders with a particular focus on transverse myelitis. Later this summer, Dr. DeSena will be establishing a neuroimmunology center at Cincinnati Children's Hospital and Medical Center in Cincinnati, Ohio. Thank you, Dr. DeSena and Dr. Newsom, for joining us today. And thank you to all our listeners for joining us and sending us your questions as well. To start us off, Dr. Newsom, could you please give us an overview of what neuropathic pain is, how it differs from other kinds of pain, and what causes it in NMO, TM, and ADEM?
Absolutely, and thank you for inviting us here today. In general, we know pain is very complex and can occur from a variety of mechanisms. Neuropathic pain being one of the most common forms of pain, it can affect any parts of the body. We would consider neuropathic pain to fall under the umbrella of chronic pain syndrome, in which can result from conditions that affect the central nervous system like transverse myelitis, or in conditions that affect the peripheral nervous system like diabetes or when individuals get chemotherapy. So with respect to transverse myelitis or other central nervous system disorders, neuropathic pain usually occurs when the dorsal horn of the spinal cord is involved. This is in contrast to nociceptive pain, which is typically described as dull or achy sensation from specific damage to special nerve endings and not the actual nerves or spinal cord itself. Neuropathic pain, which many of our listeners know well, come in many different flavors. It's described as intense shooting or stabbing pain. Some will describe it as a burning sensation or an electric shock-like sensation. It oftentimes is worse at night and unfortunately does not respond very well to over-the-counter medications like ibuprofen or Tylenol. Nociceptive pain, in contrast, since that is a common pain syndrome, does appear to respond favorably to some of these over-the-counter medications, like we see with arthritis or if you sprain your ankle. And neuropathic pain in general, at least in my experience, often needs multiple interventions to help with the discomfort, and that includes non-pharmacological therapies as well. Transverse myelitis specifically, we see more than 50% of patients experience some form of chronic pain, and a large part of that is the neuropathic pain that sets in after the TM. There have been a few studies that have shown the neuropathic pain discomfort level being more intense actually in conditions that may cause more severe spinal cord attacks, for example, neuromyelitis optica. And that sets the stage for intractable pain long term. And that goes back to what I mentioned already about the dorsal horn of the spinal cord being involved. And so if you have more of that involved, that means that more neuropathic pain could occur from that. That's sort of a broad strokes of neuropathic pain.
Great. Thank you for that, Dr. Newsom. There were a number of questions asked by the members of the TMA about different causes of pain, more specifically. So first, to Dr. DeSena, is there a seasonal or environmental component or time of day that affects neuropathic pain? And are there any reasons why pain increases or why we have these good or bad days?
Excuse me. To Dr. Newsom's point is that oftentimes, we hear that the pain will be worse at the end of the day or at night specifically. Oftentimes there are patients that have a lot of difficulty falling asleep because of various types of pain. Sometimes I will hear quite frequently that people have an extraordinary amount of hypersensitivity to what would be normally considered benign stimuli, whereas like some people would say, I cannot stand to have the sheets touch certain parts of my legs. It causes an extraordinary amount of pain, whereas earlier in the day, wearing regular clothes does not seem to bother me. It just ignites kind of a flurry of uncomfortable sensations in their legs. Oftentimes it's their legs. That's why I mentioned that. But of course, it can occur in the upper extremities too, depending on what kind of type of syndrome or where your previous injury had been. I think it's the overall question of why pain increases, good days, bad days, et cetera, is extraordinarily difficult to answer just because of the wide variability amongst the medical situations across patients. I will say from a broad standpoint that in general certain things like fatigue, stressors, either in your personal life, at work, at home, etc., anything that would cause you to have an exacerbation of other medical problems, for example, can potentially worsen the pain. We particularly focus on, in our initial assessment, and we focus on a lot of things, of course, but in one of our initial assessments, we tend to really focus on sleep a lot, just because of the extraordinary effects that an impairment of sleep can have on not only your pain but also your energy level, et cetera, throughout the day. And a lot of these areas in which patients have had TM or conditions such as NMO that have had significant impairment, they'll note that when their sleep is improved, other areas of their life will be improved, the energy level and sometimes their pain as well. That being said, it's kind of a chicken or the egg issue, especially if you're having a lot of pain at night as you're trying to fall asleep. If I can get my pain under control, then I can sleep. And so, as Dr. Newsom says, that oftentimes we'll have to incorporate some pharmacologic therapy, and to his excellent point, some non-pharmacologic measures to help reduce the amount of pain as well. In general, I think that's probably the best overview I can give in terms of, like as Dr. Newsom says, painting broad strokes about how we approach the pain, is that we really do try to make sure that as we're managing the pain, and we can try many things, of course, but we also are getting a handle on not only the medical issues, but also trying to help the individual, whoever it may be, whether it be a young child or a young adult, helping them get a handle on other areas in their life with their functioning, et cetera. And so because, as I said, oftentimes the pain will be exacerbated concurrently along with other things. That's probably the best overview I can give.
Thank you, Dr. DeSena. That kind of leads us into a couple questions that were asked out of California pertaining to increases in pain, whether it be Lermite sign or banding and numbness, where there's concern about is this something that is a sign of another flare-up, or is this something that's not as concerning?
So I guess I'll jump right in with that. So it's quite difficult. So with patients that have had transverse mellitus, as I'm sure a lot of these patients are aware, is that transverse mellitus by itself can be its own diagnosis, and in that sense, meaning it's a one-time event that happened called idiopathic transverse mellitus. And but the other concern is that it was a syndrome that is, or a symptom that was part of another, a finding that was part of another syndrome, such as neuromyelitis optica, also MS sometimes as well, and so this is part of the reason why we follow along with a lot of these patients in clinic to kind of ensure that whether this is or is not part of a larger event or a larger syndrome, such that something that would require chronic therapy in order to prevent relapses. In terms of patients that have had what we think is idiopathic transverse mellitus, it can be quite difficult to determine as they move forward at times if they are or they are not having a new flare-up. There are certain, because when we say flare-up, when you talk to neurologists that see these kinds of things, when someone says flare-up to me, my thought process is that it's a new event in and of itself that may have similar symptoms but is technically a new event. Whereas from a general term, flare-up can just refer to just a flare-up of old symptoms. And in that respect, we would not consider it a potentially new event, but just a worsening of a re-worsening of old symptoms. We tend to get more concerned if there are, even if it incorporates some of the old symptoms, if there are clearly new symptoms that the person is having that they've never ever had before. And in addition, we tend to get more concerned about this being a new event if the symptoms are clearly persistent, lasting days at a time without remitting. We tend to get less concerned about this being evidence of clearly new disease activity if the symptoms get worse, maybe last a few hours, maybe are associated with some stressors, problems at home, not feeling well, illness, etc., all of which can exacerbate old symptoms, and or if the symptoms are clearly kind of oscillating a lot or lasting less than a day or so. From that standpoint, some people are probably maybe listening to this and was like, well, I'm kind of on the fence with that. Maybe I'm having something that may or may not be a flare. If there is a concern that there is a new flare-up that might be indicative of new disease activity, that would be something that would require a discussion with your neurologist, potentially imaging, and some other investigations as well.
Yeah, if I could add to that, I think that was fantastic, Dr. Tessena. What I will tell my patients in clinic, new and follow-ups, is the 24-hour rule, which can sometimes help sort out in everyone's mind what should be concerning, what should be alarming, and what may not be so important to get worked up over. And so if there is any new or worsening baseline neurological symptom that persists in a constant fashion for more than 24 hours, regardless of the symptom, then that's something that I would recommend the listeners to reach out to their neurologist, because like Dr. Tessena had mentioned, if there is concern that there's new inflammation or a relapse or a new attack, then MRI is often the tool to investigate that. And for many people, up front, we don't know whether their transverse myelitis or their central nervous system attack is just a one-time event and, the person will go on and not have any further problems, or is this part of a relapsing condition that will need, a long-term maintenance therapy. And, a second attack or a new lesion on MRI would tip the scale towards that this is likely a relapsing condition. that would need chronic therapy outside of the symptomatic therapy. So just to separate out, when we talk about chronic maintenance therapy, we're talking about the medications that change the way the immune system's behaving to prevent further neurological attacks or episodes. Those are much different medicines than the ones that we use, for example, treating pain, treating bladder dysfunction. But I think Dr. Tassem did a great job at answering that question.
We have a question coming from Scotland, actually from a 10-year-old, so this might be a good question for the pediatrician on the call, that has had TM after 2 years. And the question is, why do I have pain in my chest and stomach area when I do too much or if I get hot in PE? And is there anything I can do about it?
So whenever any of the patients have had TM that come in and they have specifically symptoms that get worse with any kind of exertion or getting extremely warm, then we tend to put in the category that this is a phenomenon where in which patients have a re-worsening of symptoms likely from their initial TM episode that are transiently, when I say transiently, I mean briefly worsening due to subtle changes in your body temperature can affect the rate of the nerve conduction. And in patients that have had transverse mellitus, where in at least many, if not most, we feel that there was myelin involvement in which the myelin was affected, it changes the rate of conduction in which patients have had problems with their myelin, as in damage to it from TM. That nerve conduction just slows just a little bit, and some old symptoms can re-flare up. In these kinds of situations, this is actually something very common in MS patients, and it's called Udolphs Phenomenon, named after the gentleman who initially described that in these situations there is no new damage occurring. It's related often to body temperature. Oftentimes people will say it's from them getting too hot, or from exertion, because their body temperature will elevate very subtly but briefly when they exert themselves. Sometimes an infection, also like a flu-like illness, can bring this on as well. And a lot of people worry that there's new damage occurring. In general, it's fairly well known that there's not really any new damage occurring. It's just a re-emerging of these old symptoms. We tend to stress in a lot of patients that have had symptoms that are related to exertion or from being hot, especially right now I'm in Dallas where it can be quite warm in the summer, that we tend to stress a lot for the patients to have a lot of cooling mechanisms in place. And so there's a lot of cooling packs people can get. There's cooling vests that certain people can get, although those tend to be quite clunky and sometimes they're a little bit cumbersome. Just having ice cold beverages in a hand, because when you drink them in, you're putting cool fluids in your body that can cool you from the inside out. And but maybe just taking a break and just allow yourself to cool down. If it's something which can be uncomfortable, especially if it is significant pain and it's happening when you're exerting yourself, etc. But if it's subsiding fairly quickly after you cool yourself down or take a break, then we tend to not be too worried about it in terms of considering putting you on regular medication, because a lot of the times our medications that we have for pain are something that patients have to be on every day. It really depends on the individual patient in terms of how intrusive the symptom is and how much it's affecting their ability to function. Certainly there's things we can consider and can try, but in terms of when it's particularly or specifically related to heat or exertion, it's oftentimes what we feel that it is. And like I said, I just want to stress again that in these situations there's no new damage occurring. Back to Dr. Newsom's point about symptoms that flare up and that last longer than 24 hours are clearly more concerning. To that specific question, I would say that in terms of if there's needs to be something to do about it, it really depends on how uncomfortable it is, how long it's lasting, and how much it's really affecting your ability to function.
Out of Colorado, we have a question. Is there a known or anecdotal relationship between exercise and increased pain, or is it possible to decrease pain with exercise?
So I'll try to answer that. It's a complicated question. The nervous system is quite complex, and the fibers and the tracts that go from brain to limbs communicate throughout. And so if you have damage in one region, it can affect other regions, and you can have many different symptoms come from one region being damaged. And so exercise in general, it's interesting. If you look at exercise over time and what was told many years ago to patients who had neurological illnesses, especially those who had relapsing conditions like multiple sclerosis, it was told many years ago that you shouldn't exercise because that will actually bring on a relapse or cause damage. And now moving into this century, we're finding that exercise transiently certainly can provoke old symptoms, and to Dr. DeSena's points, it seems to be tightly correlated to core body temperature increasing just a fraction, and that's where some of the symptoms will be brought out or amplified, including pain. Long term, though, exercise does seem to send positive feedback to the central nervous system, and we're getting a little bit smarter in how we can evaluate people, and there are sophisticated tests that are being looked at in the research realm to try to better understand, if you exercise, does it help decrease inflammation? Does it help improve growth factors within the central nervous system? And there are some studies that suggest that. And so exercise in moderation is what we usually tell people, and that could be different for the person. And so to this person's question, if you're exercising and you get to a point where you're having extreme pain that is really limiting your ability to exercise, then what I would recommend is to look at your exercise routine and do one of two things. Decrease the intensity of the actual exercise regimen and maybe do it more often, but at shorter intervals. Or, some people will find that they can go 10 to 15 minutes and really vigorously work out, and then they start having the discomfort. So then you do just a more intense program for shorter periods of time. But exercise certainly is something that we advocate for our patients to do, because for individuals who have had any type of neurological attack, we know that pain is not only coming from the neuropathic pain, but it also comes from immobility, from spasticity. And the old saying, if you don't use it, you lose it, is very, very true when it comes to patients who have had specifically transverse myelitis. So you want to keep as mobile as possible, but within reason. But the old thought process of exercise causing more damage is not accurate. In fact, a moderate amount of exercise seems to be beneficial.
Great. On that same note, speaking of exercise, on the other end of the spectrum, is there a connection between fatigue and neuropathic pain?
Yeah, I guess I could take this one, and Dr. DeSena can add to it. So in the brain, there's an area that's very tightly correlated and intimately connected between the pain receptors, depression, fatigue, and they all sort of work off of each other. And we will see and we'll hear from our patients more often than not, if they are chronic pain sufferers, they will have an intense amount of fatigue that goes along with it, that sometimes could be associated with depression, but many times it's not. And it just happens to be that the pain is driving some central process to provoke fatigue. And what often will happen is people will get into this vicious cycle where they have a lot of pain. They're not exercising because it hurts when they exercise. They're less mobile. And over time, that creates more fatigue and more fatigable weakness and deconditioning. And so you have, in some respect, you have to strike a balance between increasing one's activity, keeping mobile, maybe fighting through a little bit of pain, and then eventually, over time, the hope is that that vicious cycle breaks where it can lift up some of the fatigue, potentially some of the mood-related issues that can go with all of that as well. And if that doesn't seem to be the case, because there is such a thing as central fatigue that may not be associated with anything else but just a relapsing condition, we see it oftentimes with MS, then there are medications that actually can help with fatigue specifically. But, you know, they do seem to be connected, and in my experience, a lot of times that's connected because of not being able to exercise as much as one would want to do, and it just turns into that vicious cycle.
Great. Thank you, Dr. Newsom. We're about halfway through the podcast here, so I want to switch gears a little bit and discuss more about the medications used to treat neuropathic pain. So, Dr. DeSena, would you mind discussing the various medications for pain, a little bit of an overview, and how they might benefit the patients?
Sure. So in general, there's various categories of medications that we tend to use for neuropathic pain, and if I'm forgetting any, Dr. Newsom can certainly jump in at any point. A lot of the initial medications that we use were initially used, or are still used in some cases, as seizure medications. And from a general sense, how they all work is that as I would say, they stabilize the neuronal membrane, and in that way hope to decrease the amount of firing that's by the nerves that is helping to exacerbate the pain. That being said, the main ones I probably would initially start with are a couple of the older medications, Neurontin, also called gabapentin, pregabalin, also called Lyrica, and carbamazepine, also called Tegretol. There's a couple others that we often will go to as well, but probably those are the first three that we kind of consider in conjunction. There's also an older medication that was initially used as an antidepressant that we sometimes tend to use just at night, called amitriptyline, also called Elavil. And those four medications, I would say, I'm correcting myself now, are probably the first medications we often use for patients who have pain. Just like every individual case is different and the factors that are affecting one's pain are different, so too is everyone's response to different medication regimens and different dosages and different medications entirely. There are patients that certainly come in that we put them on one of those three initial medications that I mentioned at a fairly low dose, and they have a beautiful sustained response in terms of their pain improvement, where before they're having pain that they would rate as an 8 out of 10, and now it's almost gone, if not gone. And then there are patients that have much more refractory pain syndromes. To Dr. Newsom's extremely good point, about fatigue and other issues, ongoing medical issues, is it's striking a fine balance between adjusting any of these medications that we initially try and also sometimes working on those other factors. And I'm not trying to bring back the discussion to that, but I just want to mention that oftentimes we're working on several issues in addition to titrating up the medications or down if it's not working and starting another medication in order to strike the right balance to make the patient comfortable and allow them to do what they need to do and to continue to do what they need to do in their life, whether it be going to school, work, etc., taking care of their family. Those are probably the initial oral medications we try. In addition, sometimes we have also tried if patients there are certain patients that come in that have very strictly defined areas of their body where they have pain that are very small and localized. In certain kinds of situations, this is not something we often do, but I would say we do it on a fairly regular basis. We'll sometimes have compounded medications that have various components of topical medications that can be mixed. And there's innumerable number of things that we've tried something that can be applied topically. Again, this is usually for areas that are just very small and localized, where some patients we've had with TM have had areas that are just in one part of their back, maybe a baseball or a softball size in terms of diameter that's involved. They say it's just there. It's just right there. That's what bothers me. And in those kinds of situations, we have tried some topical medications that have various formulations with lidocaine, and sometimes they'll have topical formulations of the gabapentin or the Neurontin, like I mentioned, and we'll mix and match some things. And in those kinds of medications, there's various concoctions that we've tried. It would have to be really a discussion between yourself and your neurologist about what they think might be appropriate or not. The reason why we would try in those situations to try something that's localized is if it's really just a small localized area, the oral medications, although in general they're very well tolerated, some patients can find them a little bit sedating. Sometimes patients will say, my thinking's on a sharper, I feel like a zombie, even though in all situations we try to start them out at a very low dose, and we titrate them up slowly to see how they tolerate it. In addition, like I previously mentioned, we'll sometimes use that medication called amitriptyline or Elavil. And when we use that medication, because it's something that a lot of the patients may or may not have heard of, oftentimes we want our goal is to have the patient on that medication for at least a couple months, if not at least several weeks, at the very, very minimum, to see if they get any benefit. When we use that medication, oftentimes we want to see how their pain is responding over a period of a couple of months before we say, okay, it's not working, before we try something else. And oftentimes we'll try that in addition to other medications, or sometimes one at a time. It can be very individualized, mainly because every patient has an individual problem, and you can have two patients that had transverse mellitus, and they had their lesion basically in the same spot in the spinal cord, and one patient could have no pain, and the other patient can have extremely refractory pain that's refractory to a lot of medications. And so every patient is different. In that respect, we try to individualize our therapy. But I would say those medications are probably the first go-to ones that we use.
Yeah, if you don't mind, I'd like to add to that. That was great. The one thing that I think is the most challenging part is to try to sort out where is the pain coming from. Occasionally we'll get hints from the history, for example, with neuropathic pain, hey, doc, I have a burning foot. You have a good idea that that's probably a neuropathic pain syndrome. But then there are other pain syndromes like chronic musculoskeletal pain that can come from, poor gait mechanics, poor seating in a wheelchair, and that sometimes at first glance may seem like it's neuropathic in origin, but it's actually not. And it's more musculoskeletal in origin. And the treatments are different, between treating neuropathic pain and musculoskeletal discomfort. And so we will often try to be mindful of that. Not every person that comes through the door, it's neuropathic pain. We have to look at other things that are causing pain, because the treatments could be different, including, you may increase your physical and occupational therapy efforts to help with the musculoskeletal pain. There are individuals that will get involved in other non-pharmacological interventions, whether it be acupuncture, massage therapy. And like I mentioned before, pain syndromes after a central nervous system attack most often will need a combination of therapies. But to Dr. DeSena's point, when we start a medication for a pain syndrome, we will often try one medication first, start at a very low dose, and then gradually titrate that to effect. And the reason being that not everyone is the same, and some people may get away with only having one medication on board at a very low dose, versus others may need a very high dose of one medication, or sometimes 2 and 3 medications. And if sort of the threshold to add on another medication is if someone's pain is only partially treated and the pain is impacting their quality of life still, then adding another medication on makes sense. And sometimes adding a medication from a different class, so then you're attacking the pain at a different level or a different neurotransmitter. And what we'll often tell people is when you're if you're pain-free or you're to a comfortable level with your pain, after a few months, you can consider slowly coming off of some of the medications, if that's possible. So.
Great, thank you for that overview. Moving into some of the more specific questions, are there any new treatments for the band-like tightness of the torso that is common with transverse myelitis?
Boy, oh boy, that's a common symptom we hear in our clinics, and it's a tricky one to treat. Oftentimes, we will try some of the medications that were previously mentioned, and if those don't seem to help, I usually encourage people to increase their exercise efforts to see if that may help increasing mobility through joints, through your back, keeping your muscles conditioned. And in terms of new treatments, there are new medications that keep coming out for the treatment of pain in general. Dr. DeSena had mentioned that there are creams that one could use. There's also lidoderm patches that sometimes people will place in the area that's has that torso band-like discomfort. If the pain is really under poor control, in addition with that torso tightness, and the person has been on many, many different medications for it, occasionally we have recommended for people to get nerve blocks in the region that's of most discomfort, and less often spinal cord stimulators. The reason we're not too enthusiastic about spinal cord stimulators is because most of the products out there are not MRI compatible, and for what we do, we want to monitor people over time to see if they need to be put on one of those maintenance therapies that's changing the way the immune system is behaving, or monitoring people who are already on medications and making sure that they don't need to switch to a different medicine. And then I think there's a big push nowadays for medical marijuana and cannabinoid-like agents, which is gaining some traction. And I think there are some prospects out there that potentially could be not so new medicines, but new for using in these pain syndromes and torso band-like discomfort, which could help.
Great. Another question from a patient from Connecticut with a cervical spine lesion asks, are there suggestions to alleviate chronic burning, pins and needles, and tightness in my hands? The pain never goes away, even with medications, but just goes from a 5 to a 10 plus on the pain scale daily.
So I guess I'll jump in. So really, it's a difficult question to answer just because of it really depends on what's been tried. And this kind of seems like a basic point, but it's a point I always stress with patients that come in, not just with pain, but with other issues that are kind of ongoing and they're affecting them daily, is that the best way to kind of continue to ensure that a lot of these things are addressed is to be keeping in contact with your provider. I always say, the care is not only at the visits. It is an ongoing process, and so I especially, whenever I'm titrating up a medication, I want them to touch base with us at the end of the goal titration. Let's say it's 3 weeks from now, and I want to hear just to get a sense of where you're at. Are you better? Are you worse? Are you the same? Even if it's a general statement like that, that can be very helpful in terms of helping to guide the provider towards what needs to be done. It could be any of a number of things in terms of does the dosages just need to be, does one of the dosages of the medication just need to be increased? Some of these medications, like for example Neurontin or gabapentin, like I mentioned previously, have a very fairly wide dose range in terms of how far up we can titrate it. We can titrate it. Others have probably a little bit of a smaller range that we can work with. In addition, as Dr. Newsom correctly very nicely points out, is that multi-mechanism therapy with different drugs that are doing different things can be quite effective. And sometimes it just takes the addition of that one additional medication or getting to a specific dose in combination with other medications that really can be helpful. Of course, there are I think someone mentioned non-pharmacologic interventions. Although it's not something I do in my practice, we have referred some patients that have had extremely refractory pain syndromes for the consideration of acupuncture. And there is some data to suggest that in some patients, in selected patients, acupuncture can be effective. Really depends on the patient, and again, to Dr. Newsom's point, is some of the patients with some of the patients with transverse myelitis have pain syndromes that are really related to gait mechanics and chronic musculoskeletal pain and joint issues, etc., exacerbated by the fact that their gait is not physiologic in how our bodies are initially designed because of the previous injury. And so in those kind of situations, that it really requires physical therapy to be involved, to help it work with the patient and say, okay, what's going on. But in terms of if it's that cold sensation or if it's a burning sensation, oftentimes that is neuropathic pain, and it really does depend upon where every individual is coming from. We've had patients that have come in to our clinic that have been followed very closely by several providers, and those providers were just working with maybe just one medication, and in that sense we said, well, we got a few options here. And then there are patients that come in and their providers have tried multiple medications and non-pharmacologic methods, and they are exercising and they are doing everything they can. And in those situations, it's a little bit more. It can be a little bit more complicated. And so that may not be the greatest answer to that question, but because of the fact that things aren't so individualized. But I would encourage the individual to really get in touch with their provider and say, hey, listen, are we where we're at in terms of what medications we try? Are there other classes of medications we can consider? Am I at a good dose? Is there possibly a higher dose I can try with this medication? Preferably those with medications where the individual feels like they did get some benefit, but it wasn't optimal benefit. And so I would encourage people to really touch base with their provider and really help them out, because as I say to the patients many times, is you are the one that's going to help me best in terms of figuring out how best to treat your pain.
Both Dr. DeSena and Dr. Newsom, you both have touched on the use of alternative therapies in regards to pain, whether it be marijuana to acupuncture. There are a number of questions from patients asking about what kind of alternative therapies there are, and are there any good ones ranging from those two to massage therapy or anti-inflammatory diets. Could you speak to that, please?
Sure. Do we have another 2 hours podcast? No, there's a lot going on in the alternative therapy world of things, and I sort of like to look at it as trying to treat the patient in a holistic manner. And, outside of some of the things that we mentioned already, treating patients from a multidisciplinary approach is important, and the challenge is trying to find what works for a given individual, because not everyone's going to respond to the various treatments that we recommend, including the non-pharmacological interventions like acupuncture. We've had a lot of patients get involved in yoga, Pilates, Reiki therapy, which provides some benefit depending on the person. Medical marijuana we talk about because that is obviously a very hot topic. There's mixed reviews about medical marijuana, and I think the mixed reviews comes down to that not everyone's going to respond to the same treatment intervention. And so there will be some people that will respond favorably to cannabinoid-like therapies, and there will be others that don't. And to find out who the right person is, it's sort of a trial and error. There are a variety of things. What I try to tell my patients is you have to be careful with Googling too much, because there are a lot of claims for various naturalistic or naturopathic medications and diets as well, where you can occasionally get yourself into trouble, because with conditions like transverse myelitis, neuromyelitis optica, MS, or autoimmune conditions in general, there's an overactive immune system that's present. And so some of the therapies that are out there that are more alternative, you'll read that it's enhancing the immune system. So I tell my patients, and I'll tell the listeners that you have to avoid those therapies, because we don't want more overactive immune system. That's what has led to the problems. But there are things like L-carnitine. I've prescribed that for a lot of my patients. There's some data to support that helps with spasticity, helps with fatigue. There's low-dose naltrexone, which quite a few people will take. And again, I think it depends on the person. I've had some patients where they say, I really feel like it's helping, and others not so much. So really, you have to look at the individual and do a trial and error with some of these other therapies that are not as well regulated, but do seem to help a lot of patients.
Thank you. That was very informative. We're going to start winding down the questions. Unfortunately, we only have so much time, and there are a number of questions coming from the patient population, including on Facebook. But for one last question, there's some concern about a patient who had a TM last year in early 2013, who has residual pain, and that their lower legs and knees have become very blue, and they don't understand why. Could one of you speak to that?
So this is something some of our patients, we've seen several patients before, that I've certainly seen quite a few times. So there's a couple of different things. So, and some patients that are extremely immobilized, meaning they have very little, zero residual strength in their legs. They tend to get a lot of venous stasis because you don't have the extra help of the muscles to help squeeze those veins, to squeeze the blood back up. And so some of those patients will have problems where they'll have quite a bit of swelling in their legs, or if they just have one weak leg, sometimes that leg will tend to get more swollen, especially if they are in a sitting position for long periods of time and they're not regularly getting their legs up. And sometimes they will get a lot of their foot or leg will feel cold, and they'll get a lot of discomfort, especially that oftentimes will be triggered at the end of the day. If we think that's a component of what's going on, especially if there's a lot of limb swelling, we tend to recommend that they try some compression stockings, and also try to keep their leg elevated at times throughout the day. Sometimes some of the wheelchairs can. Sometimes the patients will need a wheelchair that can, if they have a wheelchair that can recline back to help them get their legs elevated, especially if they have a lot of residual weakness in their legs. That can be quite helpful. That's one of the things we see. One of the other things we see is sometimes the patients will not have a lot of swelling, but they'll have some discoloration to one or both of their lower extremities that are weak, and they'll tend to get some discoloration. And just like where the nerves in the spinal cord talk to various parts of your body, whether it's your muscles and your sensory nerves, there's definitely looks like there's a role for some of them where the blood vessels are affected as well, in terms of in the end of it, the nerves that help coordinate all of the functioning in your lower and upper extremities eventually have to run through the spinal cord. And those patients, it can be a little bit of a challenge to try to treat the problem, especially if it's not causing any discomfort. So in certain patients where if they have some discoloration, and if they feel it's cold to the touch, but they don't have a lot of discomfort, then as long as they're not having a lot of discomfort, we tend to leave it alone. And if they're having a lot of burning pain, tingling pain, we typically will just again, this goes back to the initial conversation about the first medications we use, like the gabapentin, Neurontin, the Lyrica, pregabalin, and oftentimes we use that. In terms of fixing the problem, if it's just discoloration or my foot is kind of bluish purplish, and oftentimes we could see it, especially if there's not a lot of swelling involved, and we don't think it's secondary to a lot of edema, what they call edema in the legs. If there's not a lot of discomfort associated with it, we tend to not do much with it. Now, that being said, in and of itself, we don't tend to not do it, but Dr. Newsom harkened back to one of his previous points, that keeping mobile and making sure you're doing a lot of exercise and keeping the legs moving will definitely is something that provides multiple benefits over the long term. And so we try to keep our patients exercising. And I will say, I think the patients that tend to stay more mobile as much as they can tolerate, as much as they can, tend to have less issues with problems that we see with a lot of patients that are really immobilized for longer periods of time.
Thank you. And one last question before we sign off. Are you all finding that pain medicines can add issues to bladder and bowel problems?
Yeah, I'll take that. So absolutely. So the unfortunate reality, even with the most benign medications we use, there are potential side effects. And some of the anticonvulsant or antidepressant medicines that we use to treat pain can cause bladder retention, can cause constipation, upset stomach, etc. And so it gets back to the point of about having that balance between getting the pain under control, and not having too many, side effects or collateral damage, as I refer to it as. And so, if someone is having quite a bit of side effects to a medication or a few different medicines, and you can localize the pain, let's say, down to one limb, there are other interventions that one can do, like Botox injections, for example, if the pain is coming from spasticity, a local area of spasticity. And then, we talked already about the importance of keeping mobile and exercise. What I didn't mention earlier when we talked a little bit about complementary therapy, which I wouldn't necessarily consider this complementary because it's part of a rehab program, but there are various electrical stimulation devices that are being used more and more that seem to not only help send back positive feedback to the central nervous system as we see, but it can help with pain, and that is external. You're not having to take medications, and which secondarily could prevent some of the side effects that we see with these therapies. So it's a balancing act with a lot of these interventions that we do, and going back to the original sort of thing that I was mentioning, that most people will need multiple different interventions to help treat pain and other symptoms that come from the neurological illness.
Great, thank you for that. It's about time for us to wrap up our podcast today. Thank you very much to Dr. DeSena and to Dr. Newsom for sharing with us your expertise and your time, and also to the TMA for allowing us this platform to reach out to the community. We apologize for not getting to all of your questions. There were a lot of questions that came in through Facebook today and through other media, and a lot of them seeming to be about physical therapy and exercise. We will try to have a future podcast relating to those topics, and we'll try to address some of the questions that did not get asked today at future podcasts. So thank you all again for listening, and we hope that you'll listen again. Have a good day.